Screening criteria. Yes. What's it?
So after 21 years.
No, not screening criteria. I mean, what's the difference between screening and a screening test and a diagnostic test?
So a screening test is done even in apparently well patients to be able to detect a disease and then the diagnostic criteria tests that are done to confirm the presence of a disease.
I agree with that. To confirm. But the screening test, is it to diagnose?
It's a presumptive identification of the disease through.
Whose?
It's a presumptive
identification of
the disease through test examination.
So other procedures, yes.
In order to, in an apparently healthy individual.
Yes, which she said.
In order to identify those who probably have the disease from those who probably do not have the disease.
But it's not to confirm, that's the key word. Okay, and also it helps you to know the risk. Okay, it can also help to determine the risk of a disease in that particular group of people that you are screening. Are you getting that? Okay. When the patient comes, you are screening for diabetes and you see the fasting blood sugar to be 6.5 millimoles per liter. As is, what will you say?
This is a pre-diabetic.
Yes, what?
Fasting blood sugar.
Yes.
It's a pre-diabetic.
Pre-diabetic, but specifically, what would you say? Fasting random blood sugar was fine.
Impaired fasting glucose.
Excellent. Impaired fasting glucose. Can you see the risks of diabetes in that person will be?
Yes.
So can you see it helps you to also consider risk? But you should know the diagnostic test is to confirm. Screening, I mean to identify but not confirm, and also determine the risk for disease in that group of people that you are screening for. Is that clear? Okay. Okay, let's look at the screening criteria. So with the screening criteria, we should know that females less than 21 years of age require no screening. That's what we are going to say, right? Requires no screening. Females aged 21 to 64 years require every 5 years, or in the absence of HPV serology should also do cervical cytology pap smear. How often? Every 3 years. Please, are we getting that? Are we following? Then the last one, females age greater than or equal to 65 years do not require screening if previous test was what? Negative. Is that clear to you? Please, do we understand? Do we understand? Are we equivocal on? Are we unequivocal on that? Or we have doubt?
No.
We don't have doubt. We have faith. We believe that is true. Okay. Let's move ahead. Let's talk about the methods of spread. Methods of spread. We spoke about methods of spread already, right? Sorry. So the next thing we want to talk about is the diagnostic investigation. Which investigations can be done? Okay. Diagnostic investigations. Investigations to diagnose. No. We will not go to diagnosis. Yes, we are talking about screening. Methods of screening for cervical cancer in Ghana. Okay. Methods. Methods of screening for cervical cancer. In what? Ghana. So there are three methods. We'll start with the first one. The first one is what? Yes, cytological pap smear. Cytological pap smear. Cytological pap smear. This one, if you do it, you know you are going to use the brush. I know some of you have done it before, right? Some of you too have not. You've not even heard about it before, but that's fine. I mean, I know some of you have done it before. Some of you have heard about it before and yet to consider it. That's fine. But you should. Once you fall in the criteria, the categories. I mean, you should be able to do that, and also be advised on taking the HPV vaccine. It's very important to guide against the incidence of cervical cancer or HPV infections. Okay. So the cytological pap smear. Okay. What is going to be taken? The tissue is going to be taken from the transformation zone of the cervix. Okay. And usually the finding will be the presence of atypical cells. And the atypical cells, do you know what we are talking about? The ascus. When it comes to pap smear, the most common finding is the ascus. Okay? Atypical cells, atypical squamous cells of undetermined significance. They are the most common finding on cytological pap smear is ascus. Take note of that. Atypical squamous cells of undetermined significance. Ascus, the most common finding on the cytological pap smear is ascus. Is that clear? Okay. The next one is visual inspection with acetic acid. That's what we call the visual inspection with acetic acid. So this one, what is done? You see that the acetic acid, I mean, it will be introduced using a particular introducer. Okay, it will be introduced onto the transformation zone of the cervix and observe after some short period of time. What are you going to see? Your finding will be the finding will be the presence of flat aceto-whitish patches at the transformation zone of the cervix. At the transformation zone of the cervix. As the transformation zone of the cervix. Okay. Then the third one, called the visual inspection. Visual inspection with Lugol's iodine. When you hear Lugol's iodine, what comes into mind? Those who learned integrated science, those who did some bit of science, yes, what comes into mind? Michael, what will come into mind? Lugol's iodine. Those days when you were in SS in the biology lab, you were testing for what? Reducing sugars. Yes. Yes. We were testing for reducing sugars. Remember? Huh? Yes, it's right. I'm not saying it's not correct. Starch, yes. But you were testing for reducing sugars. You use iodine, right? Okay. So the Lugol's iodine is telling you that, yes, what is the impression? Yes, Fred, what would be the impression here? What is the ideology behind the use of Lugol's iodine?
When you have the iodine, what will happen is that if there are atypical cells, there will be a yellowish color.
Yes. Why would there be yellowish color?
Because they will not be able to absorb the
Yes. Then the healthy cells.
The healthy cells will absorb and turn blue black color.
Why would it turn dark blue?
Because of the presence of glucose.
The presence of
Glucose.
Huh? They don't have what? Which cells? They don't have glycogen, you are right. But the healthy cells have what? Glycogen. So if If you apply logos iodine, what will happen? Absorb. And what will happen to the glycogen? No, what will happen to the glycogen? It will be broken down, right? Into what? Glucose and what? Yes, it will reduce what? A disaccharide and what? A monosaccharide. So that's what we are talking about, reducing, testing for reducing sugars. So because the glycogen will be broken down in a reduction process, the iodine will also be reduced. So if you add iodine, okay, if you add an iodine will serve as what? A reducing agent. Are we getting that? It will serve as what? A reducing agent. In this case, the iodine is serving as a reducing agent. So if it's causing the reduction of a particular molecule, then it means itself would also undergo changes. And the change is witnessed in the color. Meaning that if you add iodine to a substance or cell containing what? Polysaccharides, definitely they will absorb the iodine, undergo reduction, and be broken down into what? Smaller molecules like the disaccharide and the monosaccharide, and there will be a color change. Are we getting that? So if you do this, you realize the finding is that the zones of atypical cells does not change color. They remain what? Yellow. That's the color of what? The iodine. Remain yellow. But the zones of healthy cells absorb the glucose iodine and change color from yellow to what? Dark blue or blue black. Okay, dark blue or blue black. The reason being that the reason why the healthy cells are changing color is because they contain hydrogen. And when the glucose iodine is absorbed, it helps in the reduction of the glycogen to what? Smaller molecules, giving a color change. Exactly. Exactly. Okay, so these are the ways by which we screen for cervical cancer in Ghana. Okay. Now, let's move on. The next one is, let's look at the diagnostic investigations. Diagnostic investigations. So if an investigation, we'll look at the diagnostic. We'll talk about the staging and also the what? The supportive. So investigations. So the first one, let's talk about the diagnostic ones. Diagnostic, what will you think of? What will you think of? Diagnostic, no, not lymph node. Cervical. Biopsy, for what? Histopathology, okay? Because remember we spoke about the histological type and the pathological types, yes. They will be the diagnostic test, okay? Then we can talk about the staging. The staging is what we were saying. The staging ones. Staging we can do BE and creatinine, true or false. We can do liver function test if the spread has gone there. We can also do lymph node biopsy, which you said rightly. Then we can also think of chest X-ray if there's involvement of the chest. We can also think of ultrasound scan of the abdomen. Ultrasound scan of abdomen and pelvis. Then we can also think of a CT scan of the chest, abdomen, and what? Pelvis. Chest, abdomen, yes. Can we do? Yes, cervical cancer, belly. It doesn't infiltrate into the bony structures like that. And we can talk about the supportive. Supportive. Supportive, what can we do? Full blood count. Yes, what else? What else? Yes, we can do examination. Why are you doing examination and anesthesia? Yes, examination and anesthesia. Then we can also do, yes, we can do clotting profile. Then we can also check for the tumor markers. Okay, tumor markers. Which tumor markers? CA125. You can also think of BRCA1 and 2. Okay. What else can we do as supportive? Yes, intravenous urogram. You are right. Intravenous urogram. Why? Because we want to check for what? Obstructive uropathies. Okay. Intravenous urogram or pyelogram. Okay. Okay, that's fine. Colposcopy can also be done as yes, colposcopy. The colposcopy is more of the vagina. Whether you want to check whether the vagina, but that one will be more of staging, the colposcopy, because if there has been an extension to the lower third of the vagina, okay, and you know what you are also talking about, okay.
What about sigmoidoscopy?
Those who also, yes, proctoscopy, they will also be for staging, okay? Proctoscopy for staging, because they would tell you about the rectal involvement, yeah, okay? Now let's talk about the staging. One of you should get, before you can get the FIGO staging for cervical cancer and put it on a page. FIGO staging. So for the staging, we use the FIGO. We'll refer to the picture. Okay. So simply put, the FIGO staging comes in 4 stages. Okay. It comes in 4 stages. Okay. The first one, you see that the carcinoma is confined to the cervix. It's confined to the cervix. If we go to stage 2, it will start involving the endometrium. Okay. But it will not go to the pelvic side walls. Okay. It will not go to the pelvic side walls. Okay. Or involve the lower 1/3 of the vagina. When you go to stage 3, it will spread beyond the uterus and involve the pelvic side walls and the lower 1/3 of the vagina, but still limited to what? The true pelvis. Stage 4, it will spread outside the true pelvis, where it will involve the rectal mucosa or what? The bladder. And the stage 4 can be subdivided into stage 4A and B. The stage 4A will say that it involves the rectal or the bladder, and then the stage 4B will be distant metastasis. Have you seen it? The stage 1 can be divided into stage 1A1, A2, stage 1B1, B2. The stage 1A1, A2 is going to be dependent on the depth. Okay, you are looking at the width and how do you call it? The depth and the extension. Okay, and stage 1A1 is more like if you have the depth less than 3 millimeters and the extension less than or equal to 7. When we come to stage 1A2, the depth will be what? Greater than or equal to 3. It will extend from 3 to 5 millimeters. But when you go to the extension, it will still be the same, less than or equal to what? 7 millimeters. Have you seen it? Please, have you all seen it? So stage 1A, 1, A2, B1, B2 before you go to stage 2. Stage 2, that's where the parametrial involvement comes in, whether it will involve or not. Stage 3, you are looking at pelvic side walls and also the lower 1/3 of the vagina. And that place you can go further in that category. And is there? Yes, hydronephrosis. That would come usually if you are looking at pelvic congestion. Yes, hydronephrosis and all that. Then the stage 4, as we rightly said, it will spread outside the true pelvis and it will involve the rectum or the bladder. Then the stage 4A, as we said, the rectum and the bladder. The stage 4B will be distant metastasis, meaning that stage 4A is more like the adjacent organs, adjacent structures. Stage 4B, you are going further, distant metastasis. Please, have you gotten hold of that? So let's make sure we imprint that in our notes. Very, very important. You said?
The summary and so on.
The summary, but it's clear. It's clear to you. We should go over it again. Oh. Who has captured the summary that we just gave? Yes, go ahead.
The stage 1 involves is confined to the cervix. And so we have stage 1A, 1, and
No, that one, the summary. So the stages are up to 4. We have stage 0. Stage 0 is carcinoma in situ. That is clear. Carcinoma in situ. Okay, you go to stage 1. The cancer is confined to the cervix. It's confined to the cervix. You go to stage 2. It's now going to the endometrium. It has involved the uterus. Okay, the endometrium. But there is no spread to the pelvic side walls or the lower 1/3 of the vagina. But when you go to stage 3, the cancer is still limited to the true pelvis, all right? But this time around, they spread to the pelvic side walls and the lower 1/3 of the vagina. Then stage 4, they spread outside the true pelvis, okay, involving contiguous or adjacent structures like the bladder and the rectum, and also distant structures. Did we capture it? Is that it? Last one. We said stage 0, carcinoma in situ. Stage 1, the cancer is confined to the cervix. Okay. Stage 2, we said that this time around it has spread to the endometrium, involving the endometrium, but it does not spread. It does not ascend to the pelvic side walls or the lower 1/3 of the vagina. Stage 2, no, that's stage 2, right? Stage 3, the cancer is limited to the true pelvis, all right, but this time around it has spread to the pelvic side walls and the lower 1/3 of the vagina. Then stage 4, the spread is outside the true pelvis, where it involves adjacent structures like the bladder and the rectum. And we are saying that stage 4 can be subdivided into 4A and B. The spread to adjacent structures like the bladder and the rectum, and the stage 4B will be what? Spread to distant structures. That's the distant metastasis. The stage 1, we said it's divided stage 1A1, stage 1A2. We said it has to deal with what? The depth and extension, where we have the maximum is 5 millimeters for the depth. The width, the extension will be what? 7. Then you go to stage 1B1 and 1B2. Then you go to stage 2. The stage 2, we have stage 2A and B. Okay, where there will be parametrial involvement without no parametrial involvement.
So with the assessment stage 4, what is it?
The stage 4, we said that they spread outside the true pelvis. Okay, spread outside the true pelvis with the involvement of the rectum and the bladder. Okay, so the stage 4 can be divided into A and B. A is what? The adjacent structures like the bladder and the rectum, and the stage 4B is distant metastasis. Okay, that's everything that we said there. Everything that's been summarized there. Okay, let's move on. Let's move on. Can we move on? Let's move on. Now, let's talk about the treatment modalities. Treatment modalities. 1, we have primary surgery. 2, primary radiation therapy. 3, surgery followed by radiation therapy. So the surgery will become primary. Then 4, you can have what? Adjuvant chemotherapy. Now let's look at for each stage according to the FIGO staging. FIGO stands for what? International Federation of Obstetricians, International Federation of Gynecologists and what? Obstetricians. It's actually a French word, Fédération Internationale de Gynecologie et Obstetrique. It's a French word, okay? And those of you who don't understand French, you bear with us. Bear with us. Don't worry. So the specific treatment. Okay. So under this, we'll say that stage 1, stage and what? Treatment. Stage 1, A1. You know the stage 1, A1. I told you already. That's less than 3 millimeters of depth and what? Less than or equal to 7 millimeters of extension. Okay. For this, you do cervical conization. Okay. Cervical conization. Cervical conization. Okay. Cervical conization. All right. Let's move on. Stage 1, A2. Stage 1, A2 means that you are going, the depth will go 3 to 5 millimeters, but does not exceed 5 millimeters, and the extension will still be less than or equal to 7 millimeters. For that one, you are going to do what we call extensive TAH, extensive TH. TH stands for total abdominal hysterectomy. We know that. With pelvic node dissection, so that we can get rid of what? Infiltrations of the pelvic nodes. Okay. Okay. Extensive TAH, extensive total abdominal hysterectomy with pelvic node dissection. Okay. The next one, stages 2. Stages 1, B1 and 2, A1. Stages 1, stages 1, B1 and 2A. The two we don't have A1, it's 2A and B. So stages 1, B1 and 2A. What are we supposed to do? So for this, we will do extensive. So this what we've done here, extensive TH with pelvic node dissection, according to the classification of hysterectomy, is known as what? Class 2 hysterectomy. Let's take note of that. Class 2 hysterectomy. Okay, extensive TH with pelvic node dissection. But if you have extensive TH with pelvic lymphadenectomy, pelvic lymphadenectomy, then that's what we call the class 3 hysterectomy. You should know that class 3 hysterectomy is the most common hysterectomy done in malignancies like cervical cancer. When it comes to hysterectomy, it's the most common used. Okay, class 3 is also known as what we call the Meg-Wedham's operation. Okay, Meg-Wedham's operation. Please, are we following? Are we following? Then stages 1, B2, 2B, 3 and 4, pelvic irradiation. Please, is that clear? Is that clear to you? Okay, we'll be ending with the complications of cervical cancer, and with the complication, we're looking at the most common cause of death in cervical cancer with regards to the complication as well. Okay. Complications of cervical cancer. So for the complications, the first one, pyometria. You know what that means? Pyometria in the endometrium. There will be what? Yes, there will be pus. Yes, there will be infection. Okay, which will lead to the formation of infected fluid, which you call pus. Okay. All right, pyometria. And that's when you are going to have ureteric obstruction. Ureteric obstruction due to the max effect on the ureters. Ureteric obstruction, which will give rise to hydroureters, hydronephrosis, and also should infection set in, pyonephrosis. That is correct. Okay. The next one, we are going to have vesical vaginal. There will be vesical vaginal fistula. It's very common. Then the next one, we will think of rectal vaginal fistulas, but that one is rare. It's not so common as the vesical vaginal fistulas. Then the next one, we can think of hemorrhage. There could be uremia, because when the cells are dying, basically there's increased cell turnover. There will be what? A lot of formation of what? Urea. Okay, urea, uric acid. And if you have a lot of urea, uremic manifestations can what? Happen. Okay? And the last one is what you said, cachexia. Please, can I clean here? This side. Are we done with? Yes. All right. Then the last thing we want to look at the most common cause, the causes of death. Okay. Causes of death in cervical cancer. Causes of death in cervical CA. Please think of these three. Whose? Hemorrhage, uremia, and cachexia. Okay, those will be the causes of death in cervical cancer. So in that regard, we have come to the end of cervical cancer. Thank you very much for your attention. I believe we shall revise and revise until we become the revised edition. Thank you very much once again, and I wish you the best. Thank you.